My name is Julia Connolly, and I'm a psychologist specializing in identification of autism spectrum disorder in various populations and providing mental health treatment for individuals who are on the spectrum. At my clinic, it's called the Autism Clinic. We serve populations anywhere from 3 years old to people in their 70s. And I think working with this population a lot, we learn a lot as we go. And we also learn that most of you will probably come across adults who are autistic, but also a lot of especially adult providers, if you have never had any kind of introduction to autism, but we kind of expect you to know. So this will hopefully be an introduction to adult autism. And what I would like to do is for our second part of this presentation in 2 weeks, I would love to get some of your feedback of what you would feel would be most helpful to learn more about, so then I can set up that presentation to meet everybody's needs as much as I can. I do also have the chat window open. I will do my best to keep an eye on that, but I can't promise. Shifting a lot of things is sometimes not easy. But also, my question to you who are here, if you could give me an idea of what your line of work is. As I understand, sometimes we have first responders, sometimes we have people who work in the schools. I'm assuming there are a lot of adult providers. If I could get an idea, that would help me just to make sure I hit on things that for most of you are the most helpful. So we will get started. Autism spectrum disorder in adults. Missed and misdiagnosed is the topic of today. Also, what we find is that some people have been diagnosed and others who don't really understand how autism presents in adults often feel that if you don't look autistic, either your autism must not be very severe or must not affect you very much. And that's a notion I'm trying to help everybody understand, that just because somebody's autism is not very visible does not mean that they are not massively affected by their autism on a day-to-day basis. Okay. How I like to start out is I feel every one of us, when we hear that somebody is autistic, has autism, or is on the autism spectrum, I feel a lot of us, most of us probably have a mental picture of what autism looks like. And I think that is a good piece to be aware of, because autism looks like a lot of different things, and sometimes autism doesn't look like autism at all. So we have an adult who seems pretty distressed. We have Temple Grandin. I don't know if anybody has ever heard about her, read any of her books. She's an autistic woman with a PhD in animal science, and she has written extensively about her experience of being on the spectrum. One of her books is called Thinking in Pictures. If you like to read, that can be a really interesting book to read and understand more of what happens inside of an autistic person's brain. Whoops, now I figured out how to make those move. Several girls. There's actually quite a few actors that have quote unquote come out or shared that they are on the autism spectrum. Autism and acting and theater is actually, there's a very strong connection. We see a lot of kids, especially girls, sort of starting out in middle school, junior high school, to have a really big interest in theater and acting. And we will talk about that a little bit more, why that might be the case. I'm just scrolling really quick. Thank you all for responding what you do. So that's really helpful. So I want you to think of, when you hear autism, what is your sort of go-to, what you see in your brain? Often that's affected by people we might know, or people who we've worked with, or other sort of mental images that we conjure as we think. So why are we talking about this? I will put this all out here. And we will provide the slides to you later, so you don't have to worry about making, like copying what's on the presentation. You will get that as a PDF. Most adults, as I mentioned, tend to not be trained in identifying autism, much less working with people who are autistic. Maybe a brief note to, you will notice me using different terms. And we used to be taught in the developmental disability community, we were taught as called person first language. So it would say it's a person with autism. A lot of autistic adults actually do not feel good about that term, and they prefer the term autistic. Some people prefer the term being on the spectrum. What I try to tell people is ask the person you're working with what they prefer and then respond to what their need is. I will use the terms fairly interchangeably today just to sort of get the idea that there are a lot of different ways to talk about this. When we diagnose, when we know an adult is on the spectrum, or teen for that matter, we need to approach psychotherapy from a different perspective. And this is often something that I think can get minimized when people do not have a lot of experience with autism. So one example is a lot of people who are on the spectrum are very, very anxious. So there's a lot of data, right, that says anxiety disorders respond really well to cognitive behavior therapy. There's also some data that shows that autistic people respond to that. I have not made that, I don't have that experience. I often find that people who are autistic tend to be very rigid thinkers, and they really struggle changing perspective and changing the way they think about a certain situation, which when you think about CBT, that's most of what our treatment focus is, helping a person change perspective, see it from a different view, and then work with that. So we need to be really careful when we treat comorbid conditions, and we'll talk about those a little bit, but things like anxiety disorders, depression, or there's very, very high comorbidity of anxiety disorders. Up to 90% of people who are on the spectrum or have a diagnosable anxiety disorder that could be generalized anxiety disorder, people who worry about everything and can't shut their brain down. A lot of social anxiety. I find the dynamics of autistic social anxiety tend to be a little different than neurotypical people who have social anxiety disorder, because autistic kids, they don't intuitively know how to do the social thing. So when you don't know and people keep telling you that you're doing it wrong and that you're being too loud or too quiet or annoying, like at some point, right, a person kind of shuts down around that and says, well, I don't know what I'm doing. And there's a lot of anxiety that can develop in that context. Medication management, I know most of us don't work with that, or possibly any of us, all of us do not work with it, but it's important to know that autistic individuals have often different responses to medication management. So when you work with a prescriber, prescribers who are trained in autism know that to use very, very small doses to start out with, because a lot of folks have really big and often negative responses to medication, and we see a lot of what we call paradoxical responses. Think of the 2-year-old that's going, or the 3-year-old that's going on a plane ride, and their parent gives them Benadryl, and instead of it making them tired, they get all wound up. So those are often things we can see in people with autism. So med management can often be much more complex than a person who quote unquote just has anxiety or depression. Knowing that a person is autistic can also help us understand sometimes really confusing things about people who are on the spectrum. So I have a client, his full-scale IQ is 140, so it's way up there. And his adaptive skills, so managing daily life, are in the 50s. So think of a person who's really, really, really bright, graduated high school, tons of AP classes, but since high school has never functioned. So then what comes up is, oh, he's one of these guys, he's in his 20s and he lives in the parents' basement and he doesn't do anything to help. That is where really damaging things happen really, really fast. Because if you were to meet him, you would understand how awful he feels that he is unable to do anything and that he actually shuts down even around this idea of being perceived by others because he has so much internalized shame and guilt about not being able to do what he's expected to do. And when you think about those kinds of dynamics, it becomes apparent that probably it makes sense that a lot of our adults struggle with pretty severe depression and anxiety disorders. As I already mentioned, incidence of mental health comorbidities is very, very high. Depression, probably around 40 to 50%. The piece I have not mentioned so far is this idea of the autism spectrum, right? I feel most people, when you hear spectrum, you think maybe of the line with the rainbow colors. But you need to shift your perception of the spectrum. It is much more something like a sound mixing pult. I don't know if everybody's seen one, but it's sort of this big, can be huge device that has tons of little knobs and sliders. And all of those little knobs represent different skills and different possible deficits. And they, for a certain person, some of them might be turned up and some of them might be turned down. So an individual who has severe sensory sensitivities is probably okay when they're at home where everything is quiet. But if they're in a situation like what's happening a lot right now is people getting admitted to receiving centers, right? Receiving centers, the U has an amazing, Huntsman has this amazing new crisis center. But when I picture an autistic adult who is in distress and they're sitting with 10, 15 other people in a room, that to me is really concerning. And it's not something that I know for a general population, being more in a communal setting is really helpful. So those are some of the things to think about and to balance when you know that a person is on the spectrum. There's a lot of misdiagnosis that happens in the adult world of people being diagnosed with personality disorders instead of autism. This could be something we could talk about next time, as I feel it's a very complex issue. One of the most common things we see is women who have pretty chronic distress, chronic suicidal ideation. There might be self-harm and they have a trauma history. What personality disorder does that look like? It looks like borderline personality disorders, especially if you're a woman. Unfortunately, the way one would manage and treat BPD is often quite the opposite of how we handle autism. And I think that's where there's a lot of things that can go sideways if a person does not have the correct diagnosis. For adults who are newer diagnosed, it can also actually help them open up some new social circles. As probably all of us know, autism translates into social difficulties, and often people feel very isolated and alone. But there are ways, especially for people who are very active online, there are a lot of ways to connect with other autistic adults, which can be really validating and healing for people to sort of have found, quote unquote, their people. So that's a piece that we often build into our mental health treatment here, is trying to help people find ways to connect with other autistic adults. Identity development, again, if we think about BPD, this is another piece that often lights up. Most autistic adults do not really know who they are, and their identity development did not happen as we would expect during adolescence. I think that can be explained by being autistic is incredibly exhausting and overwhelming for a lot of people. And what a lot of teens figured out by the time they hit junior high is that they are different and they shouldn't be the way they really are. So what happens in adolescence, instead of normal identity development, is more the idea of how do I need to act so people don't get upset with me, or people aren't mad at me, or people might like me, which then hinders actual personality development of who am I and who do I want to be. That can be really fun work if you're an outpatient therapist to work on with your clients, to really help them discover who they really are under this mask that they tend to carry around. Normal range of adaptive skills. So the adaptive skills, when I mentioned those numbers, they're all a standard distribution. So 100, between 90 and 110 would be average, and 120 and 80 would be sort of low average borderline, and then under 70 is what is a severe impairment. So when you think of a person with Down syndrome, they can often function better even if their IQ is low because their adaptive skills are better. So for somebody to have 140 IQ and adaptive skills in their 50s, so 50s are people usually with severe cognitive impairments, people who would live in a group home. Now, when you talk with a person with 140 IQ, and you would even bring up the idea of living in a group home with people who have cognitive disabilities, it's not really an option, but technically they need the same level of supports. Okay, next slide. So when we think about autism, we think about the DSM-5 makes us think about two different groups of deficiencies, since we're diagnosing by models and deficits. So it would be social communication. When we still had the DSM-4, it would have been communication and social were actually two separate categories. But honestly, there's so much overlap with those two, with social skills and communication, that they were combined into one category. I would encourage you, as much as I'm not a fan of big, huge books and only research, reading the description of autism spectrum disorder in the DSM-5, I feel is actually really helpful and absolutely worth it. Because I feel they did a really nice job describing some of these difficulties. Another piece that the DSM does really well at talking about that often gets overlooked is autism is a developmental disability. However, you may not notice it until a person is older and the demands are bigger than what their skills are. So the population we work a lot with at our clinic, I guess previously they would have been called quote unquote high functioning. Functioning labels are really tricky, as my one example of somebody with an adaptive skill level of 54. They're not actually high functioning. They're not functioning at all, even though they're very smart. So now I lost my train of thought. Sorry. But let's talk. So we have social communication, and then the other pieces we look at and look for are sensory sensitivities, and we'll go over what some of those are, and rigid thinking of and behavior. So these can be people, and that's where personality disorder hunches often come up. There are some people who will be incredibly difficult to make budge. They will feel really stubborn. They will feel like they're not trying. So those are some of the frustrations that can happen in treatment. But really, what they're connected to is the autism, and it's part of the diagnostic criteria. So if we start with social communication, the things to be aware of when you are working with somebody who is autistic, you will notice that they struggle with pragmatic language. So their IQ and verbal IQ might be really, really high. That does not mean they're good at communicating. I hope that makes sense, that just because you have a really great vocabulary and you know things does not make you good at actually interacting with a person. And that's where you start noticing differences. So most autistic people hate small talk. They feel it's the biggest waste of time, and they would prefer to never have to engage in small talk. The reason why this is problematic is that when you think maybe about yourself, is that small talk often is what opens the door to having a deeper conversation. I mean, maybe not at the checkout, the grocery checker, right? That's fine. But as people struggle making friends and they want to skip the small talk part, I think they often miss an opportunity to actually connect with a person, but they will not notice that, and that's something you might have to help them pick up on and figure out what to do with. Sarcasm can be really hard for people, and some people who are autistic are absolutely amazing and they have the best sarcasm you will ever hear, but you will need to be careful. I tend to be a little sarcastic with some of my clients that I know fairly well, and I've said things where I needed to check with the person. I said, when I said X, did that make sense that I was being sarcastic? So sometimes if you're working with an autistic person, I will always come back to this, ask the person about what's going on. Is something I'm saying upsetting? Is this helpful? What can I do different? Because you can't guess those things because people are so different, and some people will find certain things are helpful, where your next client that walks through the door will feel that was the worst idea ever that you approached it from a certain direction. So that's where always asking is really, really important. Indirect requests, like, hey, I see that plate over there. It would be really nice if somebody could put that in the dishwasher. May not happen, may not connect with the person, and then they are often seen as either not cooperative or not trying. So generally direct is helpful, but there's always a caveat in autism. There is a presentation, and this is also something we could talk about in 2 weeks, that's called pathological demand avoidance, or PDA, that I'm sure people who work with kids and teens, this has popped up. But with that subgroup of autistic people, any direct request is making them shut down, and you have to be indirect. So again, it gets very nuanced and very tricky, and you need to be really active in your work with these clients. Challenges with nonverbal communication. I mean, I think the stereotypical idea is, oh, people with autism, they don't make eye contact. Be careful with that statement. Again, there are a lot of autistic people who make no eye contact, or it feels just odd. There will be, especially women and a lot of guys too, that actually they have taught themselves to make eye contact. And if you see their eye contact as a sign that they're not autistic, you're doing them a disservice. So again, if you meet a person, let's say you know they're autistic and they make good eye contact, I tend to ask, I'm like, tell me about your eye contact. Well, I've learned over the years that that's something I have to do. Often what that does for autistic people, they have to spend like cognitive energy doing that. So then that decreases their capacity to actually process information. So here in our clinic, we have the rule, so to say, that if eye contact is not natural for you, do not force it. I want you to be able to process and be present and not need to mask or pretend socially. Um, Conversational difficulties. Um, teaching therapists to work with autistic clients will always get to the point where somebody will say, well, I can't get them to say anything. Like, how do I keep this session going when a person can't carry on a conversation? So two-way conversations, turn taking, is something we all take for granted, and neurotypical folks never think about this. Autistic people, again, they pick up pretty early that there's something they're not noticing. Some never will pick up on this. What you will see is people who go on monologues, like you get them started on a topic they're interested in or a topic that they're upset about, and they can go on and on and on and on. It's one of the issues. Other issues, people, especially when you do what we're supposed to do as therapists and asking open-ended questions, it will stump a lot of these folks. Open-ended questions can be the death of your therapy session. Actually, what we tend to do here with people who struggle to open up and to engage is we call it 500 questions. And we will ask a lot of yes and no questions to kind of narrow in on certain subjects. And that is really exhausting when you're the therapist, but it can really help people who struggle expressing themselves, help them communicate in a way what they're struggling with and what's going on. Autism is almost always a game of extremes. So we have people who talk too loud, people who talk too quiet, people who never shut up, and people who never say enough. So when you see those kinds of extremes in communication, that is often a red flag that you want to dig a little bit deeper. Perspective taking and social inference is really tricky. As I mentioned earlier with CBT, it can be hard, right? When you're saying, and I run into this when I work with my teens, and I was like, so the kid did X. To me, it's like, well, the parent would probably be upset. I asked the kid, I say, so how did your mom feel about this? And they look at me like, well, how am I supposed to know what my mom felt when this was happening? She looked angry, but I don't know. So this idea that you can see a situation from more than one perspective is something that's worth working on, and it can be really hard. Sometimes I use very concrete. I have a client who's like, I don't struggle with perspective. She does. Like she's one of the hardest to communicate with. But I sometimes get as kind of specific as holding up my phone and saying, when I hold up my phone, you see something very, very different than what I'm seeing. And I think that's something we often sort of take for granted that people make that connection, but in autism, that can be really difficult. Um, Unusual social style. So, when everybody's heard or thought this person looks autistic or they don't look autistic, there are a lot of folks who are on the spectrum. This when they walk through your door, you sort of automatically feel there's something different. And that can oft also be somebody who has severe social anxiety, right? Like they look more awkward. But when you see people, we see with autism, we see kind of a lot of kind of movement somehow back and forth. There's often a lot of fidgeting. There's people who don't really care so much to, when you look at their dress, it's maybe looks different than what you would expect. Like there's a lot of comfortable clothing, a lot of sweatpants, shorts, and t-shirts, maybe even in situations where you would expect somebody to quote unquote dress up. And that's where things can get tricky, how to help a client find when do you maybe need to dress up and when is it okay for you to just be who you are and not mask. We will talk about masking in a moment. So masking or camouflaging. And so masking is the idea that, and I think in mental health, we've talked about masks for long times with a lot of people, right? With anxious, depressed people as well. But there's a lot of things with autism, these are more extreme. So really a lot of what people will do, especially people who are more socially aware, they will find ways to adapt to a crowd and behave and act just as the crowd is doing, which we talked earlier about with identity development is really tricky because when you hang out with your quiet friends, then you're really quiet. But if you hang out with what would be a group? It's not uncommon to hang out with kind of the kids that smoke weed at high school because they're accepting and they're nice and people will try and fit in. Which I think often is confusing for people when we think about autism, because a lot of people think autistic folks don't have a lot of social awareness. But like with everything, there are a lot of people who have very limited social awareness, and autism often is easier to pick up in those folks because they tend to just look how they look and they are who they are. But when you get people, especially we see this with the female autism presentation, where people are very almost hyper aware of what everybody's doing around them, they try to come up just with the most extreme ways to fit in that you can think of. And again, we'll touch on masking a little bit later. Sensory hyper or hyposensitivity. So remind yourself it can go both ways. So sound, probably most people have an awareness that a lot of people who are autistic are sensitive to loud noises. So a lot of it can be helpful when you have an autistic person working with an occupational therapist. There aren't a ton of adult OTs, but really working on adapting to those situations. So I would say 80% of our clients, when they come to our clinic, will have some sort of headphones. That is sort of standard attire for a lot of people. Noise canceling has probably been the biggest gift to the autism community ever, that you can just shut out some of that ambient noise that's constantly coming at you. A lot of spectrum people struggle to filter their focus. So I think most of us, we can be in a noisy environment, but somehow our brain filters out certain parts of the noise. And that filtering does not happen the same way in most autistic brains or nervous systems. Something you will hear from a parent sooner or later is to say, well, my kid says they're insensitive to noise and they're the loudest person ever in the room. Those two things can go together because when you're the one making the noise, for one, it sounds different and you're the one in control. And being and feeling in control can be really, really helpful with anxiety and autism. So for kids or adults, we have a therapist who's autistic, and she says, I mean, from when she was little, everybody's always told her she's too loud. She says, I've tried all the things, people have told me enough times, this is something that's part of me and I cannot change. And then that's something to work with as well. Because it's, again, how much do we want a person to be processing about how loud am I? How am I moving? Am I looking right? Am I looking at the person? How much capacity do you have as an adult to still do the things we expect you to do? I mean, therapy is one thing, but I mean, thinking about we see very, very strong genetics, family genetics in autism with our population. So when you have a mom who's autistic and she has 4 autistic children and a husband who's also autistic and has ADHD, it's a really, really tricky sensory environment to manage. Light sensitivity, also very common, especially bright lights. I feel a lot of my clients have the transition lenses that turn dark. So sometimes I find when you walk around the recess at elementary schools, the kids that at that age already have transition lenses that get dark, there's something sensorized, or they have something with their eyes that really, but it's one of those little red flags. A lot of people really sensitive to smell, which in a lot of situations isn't that big of a deal, but also when there are people who insist on wearing a lot of perfume or cologne, or the middle schoolers that all need to do Axe 5 times a day, like it's not a good situation. Oh, and there's a mistake in spelling. Taste. A lot of taste and texture issues. So we know a lot of kids end up with the RFID diagnosis, which is the real huge anxiety about eating and trying new things. When you have somebody with that diagnosis, I feel autism needs to be ruled out and made sure that it's not part of the picture. I feel RFID and sensory processing disorder to me are always at least a red flag to rule out that autism isn't part of the reason why a person is struggling with that. A lot of adults still are very, very sensitive to food, and they look like the picky eater kids that everybody rolls their eyes, and you need to accommodate. So a lot of adults will talk about what's called safe foods. Safe foods are often foods people can eat almost always. And when they are more dysregulated, struggling, like I'm thinking inpatient hospitalization, their need for the foods that they can tolerate sort of it increases the rigidity about having just the right food, or people really struggle with continuing to eat. Proprioception, interoception, I don't know if everybody's familiar. So proprioception is your ability to feel where you are in space. So when you have somebody that's constantly too close to you, part of that is often that they don't read the situation right. They don't know how close they are. They don't know how it's affecting you. I mean, we've had kids when I used to work up at when it was still uni. We even had a 6-year-old once. We thought about attaching a hula hoop to him just so he would notice when he would bounce into people to learn a little bit. I mean, here's the space. It's really hard to learn those things when your body doesn't do those things well. Interoception is your ability to feel what's happening inside of your body. And that's something in therapy we actually talk about quite a bit. So this can be anything from I'm feeling distressed or I'm starting to feel uneasy to also people not noticing when they're hungry. So there are quite a few autistic adults who will not get this internal signal, you are hungry, you need to eat. And then they're also more sensitive to blood sugar, so then they don't eat. And then they get dysregulated and we get into a huge spiral. So sometimes the focus is on very basic, when are you eating? How do you know when to eat? And we work with timers and all sorts of things. We had a client who didn't respond to any of the ideas we had. What worked eventually is that she was really, her special interest was insects. And she had, I don't know how many different kinds of little creatures at her house, but they needed to be fed really consistently. So we ended up combining with her, when you're feeding your critters, you need to also feed yourself, because otherwise she just wouldn't think about it. So sometimes you have to be really creative and figure out how to work through some of these, especially sort of the basic needs that a person has to be able to function. Pain sensitivity and tolerance can also be very different in autism. Anything from, I met a family once, their 3-year-old was not verbal, was not communicating yet. And they didn't realize until nighttime when they were giving the kid a bath that they had somehow climbed on a counter and stepped on the heating element. So they could see the burn on the foot. The kid never cried. Was never any indication that something really bad happened. So when you think about that, we know pain signals us a whole lot of things. And when people don't notice their pain, that can be really tricky. We also see the opposite. We see people who are very sensitive to pain. Um, like I have a kid, he's 13, and it looks like not a big deal, right? Those are the kinds of things when you're like, come on, it's going to be okay. But I really think my kid has a really low pain tolerance. So he feels things a lot bigger. And we need to respond to that, even though often we as parents, and I'm included, sometimes feel like, oh, it can't be that bad, just keep going. But when I work with adults and they tell me their parents did all this, the adults actually never learned where the limits were for what they could do. And that's something that a lot of adults on the spectrum really need to learn. How much can I do before I melt down or before it's just too much? Rigid thinking and behavior. So most autistic individuals have a pretty strong need for predictability and consistency, which is great, right? We can come up with routines and schedules and those kinds of things. The tricky thing is that life never happens the way we would like it to happen, right? There are, especially when you have an autistic parent who has kids, like how predictable are our kids, even kids that don't have any other mental health or developmental issues. So that is really important. We work in therapy quite a bit on setting up predictable structure at home. And that is helpful, but it's often really hard to make people be consistent enough to get into a routine. I always say when people have a healthy routine, that's really awesome. Getting there and kind of trying to force a healthy routine is really hard and takes a lot of time. Okay, question. Do you see those with autism become addicted to medical diagnosis, seeking for additional diagnosis as an individualistic identifier, also using this as an avoidance coping skill? Um, I mean, I find there is, in general, a lot of autistic adults with, normal or high IQs. They want to understand why things happen. because the more you understand why something happens, the more predictable it is and the more you know how to respond to it. So I'm not sure if it's as much avoidance. I find it more as trying to understand better, but it's really tricky. We have a couple really tricky clients at the clinic, and they end up with several diagnoses. So we have, autism, PTSD, a lot of trauma in people with autistic people, partially because they are really sensitive people on an emotional side. Also OCD, there's question if there is a mood disorder or not, because we definitely saw some pretty significant swings. So I think to me, it's more about the importance is to accurately diagnose so the treatment can be helpful, right? So we're not doing damage to a person. For example, an adult I recently met for a diagnostic consultation who had been diagnosed with OCD for the last 20 years. The more I talked to him, and he said, well, I don't think I really had obsession or compulsions, but my treatment provider really wanted me to felt as had compulsive behavior. When I dug out a little bit more what was going on, he says, well, for example, when I take something out of the oven, I feel I need to do this. So he showed that to me, and I'm like, that's not a compulsion, that's an autistic sensory seeking behavior. And when you suppress those, so the treatment team there had really tried to get him to stop doing those things. And that actually then moves into pretty severe masking, which, as we're going to talk about later, decreases people's mental health. And really what he needed to do is probably find more opportunities to move and do some of the things his body wanted him to do. So I think that's where critical correct diagnosis is really helpful. And I think when their autism is part of the picture, it's important that that gets figured out. But yes, there are a lot of, I also see quite a few adults who have chronic medical issues. So we have several clients who struggle with chronic fatigue syndrome, ME/CFS. And it's one of these diagnoses that by history, a lot of people have said, oh, it's just kind of it's not that big of a deal and you're just not feeling really good. And clearly it's something very different, but it's something that's hard to find medical evidence for. So I tend to see that more, that people get minimized than that people feel they have these things that they really don't have, just to kind of collect diagnoses. Will you be talking about some of the overlap between ADHD and ASD? Yes, we can do that. If we don't get to it today, that might be some of the things for us to talk about next time as well. There's a ton of overlap, and I think sometimes it's almost impossible to tell the two apart. And recently, there is a genetic study where they actually found a shared differences in a very specific spot on a chromosome for autism and ADHD. So there's very likely that there is a subtype of, people online call it ADHD, but that has sort of both together. Those folks often tend to look less autistic, but you need to still understand both pieces. So we can get there, hopefully. Difficulties with change. And that can be tiny changes. So that's not necessarily, we're going to go buy a minivan, but we bought a truck. But that can be things like somebody moving something around in their environment. And it's tricky, right? Let's talk back to you're working with adults who are probably parents. When you're a parent and you have 3 kids or 4, or I don't know how many people in your house, stuff will get touched and moved. Right? Like at my house, there was an adult Lego room, and that was locked up when my kid was little, so he wouldn't go in there and move stuff because it would be too triggering. So being aware of that, but also so one of our triggers for emotional dysregulation often is what we call the change in plans. So, I plan today after work, I plan to go pick up my son and get dinner. But I pick him up and he says, no, I don't want to go dinner. I just want to go home and be on the computer. That can be a huge trigger for dysregulation. Often what we see also is that individuals have a plan in their head that they've actually never communicated to anybody. So then when everybody's doing something different, they get really dysregulated and everybody's like, well, we didn't even do anything, but the person thought you guys were going and doing a thing or not going anywhere and doing a thing. So in therapy, we're really working on people communicating what their plans are can be really helpful just so people can check in with each other. Very rule-bound thinking. This can get people, I mean, worst kind of trouble is legal trouble, right? And we see that quite a bit. I had a client who says, please tell my story so people can understand and help people like me. He is actually at this point on the sex offender registry because he connected with what later we found out was a 16-year-old boy, but it was through an app where you had to say, you are 18 years or older. So he said, well, everybody who's on this app is 18 years and older. And then he had sex with a minor and is on the registry, being completely clueless. He thought he had done all the things he needed to do. So that's where rule bound can be really helpful sometimes, but it can also get people in trouble. Black and white thinking will be your constant companion during therapy with autistic adults. And I know not just autistic people are black and white thinkers, but the severity of it, I feel, is sort of stepped up from what I've seen with neurotypical people. So there's a lot of, well, it never will get any better. I can never, ever again do this thing. Or it's always, I know what to expect. All the bad thing always happens. And those are really hard to shift in therapy. And it takes a lot of time and a lot of kind of repetitive examples of how to maybe do that. Can a trained LCSW or CMHC in autism provide diagnosis, or would you suggest? So I would look at the rule that, as far as I know, only PhDs are allowed to diagnose autism. Do I think that's right or wrong? Different story, right? I feel if you have a client and they tell you they think they're autistic and you are like, yeah, you're autistic, I feel you should be able to make the call. But I think right now, with according to Utah law, you can't. But I saw somebody on social media saying that that has changed. So I would encourage you to check that. If something is not clear and you think there might be autism, referring to somebody who specializes in diagnosing adults, I think can be really helpful because there are a lot of people where you're like, I just don't know, but I definitely have the hunch. So I do diagnostic consultations, and what it's only for adults. And what I tell people is I can tell them if they're on the spectrum or not, usually after the consultation, but it's not something they could take and get SSI or get disability because I wouldn't be, but it's a cost-effective way for people to get a diagnosis. Where otherwise, for some people, I think it's helpful to get full testing and to possibly also look at their cognitive skills. And we see a lot of problems with executive functioning and sort of neuropsych issues. So that can be really helpful. Um, I know somebody found the form. If you could tell us what that says, that would be helpful. Um, oops, sorry. Perspective taking, as I mentioned, really hard. Rigid social expectations. So they might expect you to do things a certain way, and if you don't do them, they might get kind of irritated. If you feel there are expectations that are not spoken and something doesn't feel right between you and your client, ask. Same thing. Always like, if you don't know, ask the person. That's what's really fun about this population. They're usually pretty direct and straightforward when they're able to verbalize or articulate something. Perfectionism, I know probably all of you have worked with that in one capacity or another, but when you're an autistic person that needs things just so and they're perfectionistic, it's a really tricky combination because often they don't even want to try something new because they know they're not going to be good at it. So you have to really work the process of how do you get to be really good at something. And I feel when you think about all these things and therapy, right? I feel we do a ton of work before we even get to doing the therapy we usually want to do. It may be half a year that we're working just on how do you do therapy? Can you be flexible and thinking about things a different way? So that sometimes can be frustrating for therapists because you feel you should be able to jump into the actual interventions, but you have to take your time with that. And it's probably the hardest piece when I train therapists on how to do this, or my interns, right? There's always I feel like I'm not doing therapy. It's okay because you need to also establish this safe connection. And a lot of folks with autism have been hurt in social, emotional ways throughout their lives. And for them to establish that you are a safe person that then they can be open with about the weird things they do that they're self-conscious about, that rapport building component takes really, really long. And you need to be patient with yourself too, because you might be feeling there isn't progress fast enough. Dang, we're close. Okay. Repetitive behaviors. I put special interests in there as they count in the DSM, they count as part of this repetitive behaviors cluster of things. Special interest is kind of a weird term, but it's been sort of the term we've used forever. It's the things people really, really enjoy. And that can be a really great way to connect with an autistic person, is if they can share what they're really interested in with you. It can really break the ice. What you will see with a certain subset, especially late teens, so 17, 18, 9-year-old, 19-year-olds, sometimes I cannot get it out of them because they've been told so many times that whatever they're interested in is either dumb or stupid or a waste of time or any other negative thing you can think about. So sometimes it takes some time to even coax that out of people. When people really don't have a special interest at a certain time, that's when I get actually really worried about a major depressive episode that's severe, when people even lose the interest in the things that usually they kind of, their eyes sparkle a little bit when they can tell you about. I mean, for the kids, what is it? Minecraft, games. But it can be things like certain sports. Unfortunately, for a lot of autistic girls, it's boys. Like this, it can be anything, right? It doesn't have to be trains or cars or so. Find out about this stuff. It can help you connect. Motor body movements. So everybody, has the stereotypical hand flapping, but you would be surprised how many kids were hand flappers and nobody still thought that autism was a piece of the picture. The important things about body movement is that it's something that makes people look really different and draws attention, which usually they don't want. So either other people or themselves have trained them not to use those stimming behaviors. But what research is showing us, the more that especially these physical manifestations of autism are suppressed, the more you will see mental health challenges pop up. It's a way for people to regulate. And when you take that away, they can't regulate. And it's almost like I see this bucket that's overflowing with emotion and stuff that needs to come out. Um, Verbal repetition. So when you think about classical autism, this was often it's very noticeable. Kids that say the same thing over and over and over again. But when you think about more socially acceptable ways of doing that, songs, like people will be stuck on the same song forever. And it took me the longest time to figure out why is that even a thing, but it feels very comforting to know exactly what's going to happen. My spouse is autistic, not officially diagnosed, but we will go through sort of repetitions of certain movies for a couple months, and then it switches to a different thing. And I'm like, okay, we've switched what the thing is right now. But think about those things as comforts. Those help regulate, those are comforting. You know what's going to happen. So I always really encourage those kinds of things, even though a lot of adults try to suppress them because they feel it's weird or it makes them seem different. Routines, rituals, they can be beautiful things, and sometimes they can be really non-functional and keep people from doing what they really need to do. However, a really functional one I heard about last week was this guy who he has a certain way of making his oatmeal, and he prepares 14 jars of oatmeal that he has lined up in the fridge, ready to go. And he said, well, we had people over and wanted to do breakfast with them. And He's like, the only thought that was in my head is like, I just want to have my oatmeal. I just want to have my oatmeal. But what I should do is I should have bacon and whatever, because that's what socially is happening. So those are a lot of the decisions that adults are almost constantly making to figure out what should they be doing. Sensory seeking behaviors, anything like rubbing soft things, rubbing hard things. A lot of kids, when they get dysregulated, they want to grab something hard or pinch. When you're an adult, that's kind of hard, right? You can't just walk around the office starting to pinch people. So those are things that in individual therapy, we really try to work on what are ways you can get this input without causing a problem. So we don't try and shut it down. We say, okay, clearly you need some strong input. Is there a certain fidget? Therapy can be really helpful. It comes in these different consistencies. And when you use the stuff that's, I don't know what they call it, it's extra hard, like you really have to work it and that can give some of the same input. Well, I know a couple people, okay, talk really quick about masking and you will get the handouts. And please, if you send whoever an email, let us know what would be most helpful to go into more detail next time, because I want it to be helpful for you guys, and there's a lot. So masking is conscious or unconscious, so it doesn't have to be something a person is aware of. The classic example is when I meet and this is more in women, they will say, well, starting in second grade, I knew I wasn't like the other kids. So I started watching what they do and I started copying how they behave. I had one person who took a journal out to recess and she would write down conversations other kids had and then she would memorize them. But think about how weird that is. If you see this kid that's like copying what other people say, a lot of people wouldn't think, oh, that's autism. They're like, oh, you're weird. But this is what people do. And everything that we're learning from research so far shows that the more a person is masking, the worse their mental health becomes. So this is where therapeutic work is really important to help a person. Clearly, you can't just do whatever you want, right? You can't just walk in your underwear out on the street and go shopping. So you got to put on some pants, even if that's not what feels good to you. But we really try and find out what are the absolute necessary skills, things you need to do. So I will end here. Um, PDA would be, yeah, PDA would be awesome. And it would be a whole extra because I think it's such an opposite presentation of autism than what we usually see. Yes, trauma, mental health in general. So just think of what would be helpful and I will try and hit on the most helpful spots. And maybe next time I'll also build in more time for questions so I can really respond to what you guys are thinking. And thank you for all for being here today. And then I will see you in 2 weeks.
Julie is still online with us today. If you have a quick question, you can feel free to unmute yourself. Maybe just ask it or drop it in the chat. I'm happy to send that along to her as well if you're unable to unmute yourself. But the time is yours to ask any questions.
I don't have a question, but I do have a comment. I have never thought of the 1,000 questions. And I love that. That's the one thing that stood out to me. Because you've been taught in social work to ask open-ended question, let the client talk. I have never thought of that. And I was like, okay, put in that somewhere because yes, that 1,000 questions does work. And you're like, why are they not responding? But
Yeah, they can't. It's too vague often for them, and then it's too big of something to draw from.
yeah,
So I think there are quite a few therapy things we do that usually you're taught not to do. And it takes
yes.
a little bit of changing and thinking that it can actually be helpful for some people.
Yes, and I love also my second comment was I love the remembering that autism looks different for everybody. I think a lot of, this not the myth is it's this way. But I love that yes, some kids can't do sound and some kids can, and it's just different for every, so it's so hard to, um, I work in the schools, so it's so hard to help a teacher understand that this autism for this kid is not the same
Uh,
as the autism for that kid, because it's not one
And it can
single,
change day to
yeah.
day depending on how overwhelmed a kid is. Like they're the kids that sometimes they can, write a whole paragraph and then the next day they can't write a sentence. And teachers are like, well, I know you can do it. You need to just try. And they're shutting down and feel awful, but they can't. So that fluctuation, even within the same person, is really tricky.
Great. Any other questions or comments?
So I think the trick for next time might be to say, are we talking about the sort of, there are a lot of comorbidity and autism, right? OCD, trauma, anxiety, depression, ADHD. Or we could focus also, also might be hard in an hour. But then the other direction could be talking about how do you navigate these things because it is really tricky and it takes a lot of resources. We tend to see people of the same family system, different therapists in the building, so we can put our heads together and say, here, but those are really good questions. And we should talk about them. We will see if we can get there. But I can tell you it's an ongoing process. I mean, there is never the let's have 10, maybe even 20 sessions and it's fixed, right? Like we're always continuing. And then the kid, now they're suddenly a teenager and they're not 12 anymore. And so it's really, we almost feel more like we're escorting the family along the way of getting through life rather than sort of have an intervention that heals or cures or fixes something. Okay, so there's kind of both the need for more learning about the comorbidity and sort of more of a hands-on how to, what do I do? Well, thank you all for being here, and then we'll take your feedback and hopefully make the next hour as packed with helpful information as possible.
Thanks again for your time, Julia. This has been an amazing presentation, and we're looking forward to part two.
Well,
So,
thank you
oh,
all. And I will send that right now, the attachment, so you all can have the slides.
fantastic.
Thanks, and I'll see you in 2 weeks.
Sounds good. Thank you for your time, and thank you everyone for showing up today. This was a lot of fun. Remember, we're going to do this again in 2 weeks for part two. So mark your calendar for October the 28th. We're going to do it at the same time. So 12 to 1. We'll do it virtually. It should be a lot of fun. So hope to see you all there. And I will read over all the comments and all the feedback in your evaluation and make sure that Julia gets, your requests for any elements that you want us to go over next time as well. So thanks again for your time and enjoy the rest of your day.